Hello everyone, welcome to Sums Up. Today we are tackling one of the most high yield topics for USMLE, heart murmurs. And I'm going to make this super easy for you with a simple 5-step algorithm. Let's dive in. So here's the game plan. The 5-step algorithm: first, determine what phase of the heart cycle is it. Step 2, where do you hear it? Step 3, what does it sound like and what are the buzzwords? Step 4, how does it change with maneuvers? And step 5, what clues does the patient history give you? Master these 5 and murmur become almost automatic for you, especially on step 1. Alright, step 1, figuring out the murmur. Is it systolic or diastolic? This alone narrows your diagnosis in half. Systolic murmurs happen during ventricular contraction. That's between S1 and S2. So your big 4 systolic murmurs are aortic stenosis, mitral regurgitation, tricuspid regurgitation, and ventricular septal defect. You have to memorize it, no way around it. So aortic stenosis, mitral regurgitation, tricuspid regurgitations, and ventricular septal defect are your systolic murmurs. Easy way to remember: think the heart is squeezing and something is blocked or leaking forward. After this, the diastolic murmurs for heart are aortic regurgitations, mitral stenosis, tricuspid stenosis, and pulmonic regurgitations. Quick memory tip: diastolic murmurs are almost always pathological. If you hear diastolic, think something is seriously wrong with that valve. Diastolic murmurs are always and almost pathological. This comes on step 1, step 2, stems mentioning diastolic murmurs and what is the next step in management. So diastolic murmurs are almost always pathological. Remember this thing. If a murmur is continuous murmur throughout the heart cycle, it is PDA, patent ductus arteriosus. Remember this one, it's a very common USMLE favorite question, and if you hear anything like this continuous murmur, just go for patent ductus arteriosus. Okay, after determining the phase of the heart, the next thing or the next step we would look forward is location of auscultation. This is one of those things that sounds intimidating at first, but once you know the 4 landmarks, it becomes second nature. Think about it: every murmur has a home base on the chest where it's loudest, and no, that home base is often enough to crack the diagnosis. So let's map it out clearly, one spot at a time. So if it's on the right side of sternum, okay, right side of the sternum, it's this place, this A, where it is written A. Right side of the sternum, second intercostal space, that is your aortic valve area. Now moving to left intercostal space, it's your pulmonic area, P. This pulmonic area, second intercostal space, it is left second intercostal space, it's pulmonic area. Now going here at the 5th or 4th intercostal space on the left side, that's your tricuspid area. It is the tricuspid area here, and that going forward in mid-clavicular line in 5th intercostal space, it's your mitral area here, this also known as the apex. Basic mnemonic for this is: all patient take meds: aortic, pulmonic, tricuspid, and mitral. All patients take medicine: aortic, pulmonic, tricuspid, and mitral. So coming back to it, now if it's on the right side of sternum, aortic valve in second intercostal space; left side of sternum, pulmonic in second intercostal space; tricuspid 4th or 5th intercostal space; mitral area fifth intercostal space, mid-clavicle. So we have discussed so far the two steps. One, determine the phase of heart. Number two, where to place your stethoscope or where to hear the heart, aortic, pulmonic, tricuspid, and mitral positions. Now, going on the third step, it is intensity and buzzwords. This is where the exam really tests you. So let's slow down and look these in one by one. So these are the murmurs and buzzwords related to them, and these are on the right side of the heart. So the first one, aortic stenosis, aortic valve, harsh, crescendo, decrescendo, radiates to carotids, and pulses parvus retardus. You will feel a weak delayed pulse called pulsus parvus retardus in aortic stenosis. Picture blood squeezing through a tight valve. Second, aortic regurgitations, early diastolic blowing murmur. Look for pounding pulses and a wide pulse pressure. The blood is leaking back so the vessel feels the extra volume. Third, mitral regurgitations, hollow systolic and blowing radiates towards the axilla. Easy memory, MR goes to the armpit. Mitral regurgitation goes to the armpit. MR goes to the armpit. Mitral regurgitation goes to the armpit. Okay. Now fourth, mitral stenosis, classic for an opening snap followed by low rumbling diastolic murmur, heard best at the apex when the patients lie on the left side. That's for down. Aortic stenosis, aortic regurgitations, mitral regurgitations, and mitral stenosis. Now same intensity of murmur and buzzword on the left side of the heart. What valves do we have on the left side? It's tricuspid. So the next one is intensity of murmur and buzzword, left side and special cases. So remember, this left side and this right side I'm pointing towards in these two slides, it is with respect to sternum, not the left side of the heart or not the right side of the heart. It is left side of the sternum or right side of the sternum. So first we discuss the right side, now we are discussing the left side. So it is tricuspid regurgitations, hollow systolic. Hollow systolic means throughout systole, increase with inspiration, also known as Carvallis sign. Next up we have pulmonic stenosis, systolic, harsh, increase with inspiration. Seventh, we have ventricular septal defect. It's also harsh, hollow systolic, loudest at left lower sternal border, may have thrill. And eighth, PDA, patent ductus arteriosus, continuous machine-like murmur, best heard at left infraclavicular area. So some of this information might be getting back again and again, so that you may remember, and it may be a little bit confusing, these two slides, cause I have divided them on the basis of sternum, not the heart. And the thing here which is says increase with inspirations, so always remember that the if we are talking about the right side of the heart or right chambers of the heart, those murmur increase with inspiration, and heart is not lying like it's not half to the left of the sternum and half to the right of the sternum. It's like this kind of oblique, which is only a part of it is on the right side and the rest is left to the sternum. So that's why it may sound like little bit confusing, but if you hear this video again and again, you will get what I was trying to say or conveying to you guys. So after that, the first step, we have maneuvers. So what are maneuvers? This is a big one for USMLE Step 1. The core concept is simple. Maneuvers are exercises or some kind of activities which change venous return preload or after load towards the heart, and that changes how loud the murmur is. So first we would talk about inspiration. So what is inspiration? What happens during inspiration is that venous return to the right side of the heart increases. Now I am talking about the right chambers of the heart. So when venous return to the right side of the heart increases, right sided murmurs like tricuspid regurgitations and pulmonic stenosis increases. The same concept I tried to give you on the previous slide, and it has returned here again. Right sided murmurs like tricuspid regurg and pulmonic stenosis increase on inspiration due to increased venous return to the right side of the heart. Left sided murmur, aortic stenosis, mitral regurgitation, mitral stenosis, aortic regurgitation decreases on inspiration. Getting my point here? Inspiration, right heart louder. Now the second thing is expiration. Now what happens during expiration is blood flow to the left heart increases. Left-sided murmurs like aortic stenosis, mitral regurgitation, mitral stenosis, aortic regurgitations, they increases. Expiration, left heart louder. Okay. Now Valsalva strain phase, the effect of this maneuver is decrease venous return, decrease preload, most murmur decreases. Exceptions, there are two exceptions to this: hypertrophic cardiomyopathy, which increases louder on Valsalva maneuver. Second is mitral valve prolapse, earlier click plus longer murmur on Valsalva maneuver. The next maneuver is standing up. What happens during standing? Venous return to the heart decreases, similar to Valsalva. Most murmurs decreases, same hypertrophic cardiomyopathy increases, and mitral valve prolapse increases on standing up. So basically on this slide what I'm trying to convey is that all kind of murmur decreases when the venous return to the heart decreases. Only hypertrophic cardiomyopathy and mitral valve prolapse increases. That's the whole point here. Next up we have squatting, leg raises. What happened during it? Venous return to the heart increases and after load also increases. So hypertrophic cardiomyopathy and mitral valve prolapse decreases. Most others, aortic stenosis, mitral regurgitation, aortic regurgitation, ventricular septal defect, all increases, but hypertrophic cardiomyopathy and mitral valve prolapse decreases. Squat loudens most, softens cardiomyopathy and mitral valve prolapse. Similarly, hand grip, it is an isometric exercise. Effect is increase after load. It increases regurgitant murmurs like mitral regurg, aortic regurg, and ventricular septal defect. So the whole point here it is that these two maneuvers, it increases somehow the blood in the heart. So whenever there is an increase blood in the heart, all kind of murmur would increase except hypertrophic cardiomyopathy and mitral valve prolapse. And this hand grip, it causes aortic stenosis to decrease. The change in murmur, if there is hand grip and change in murmur is heard, this might be aortic stenosis most of the time, because aortic stenosis, the gradient across the valve decreases in this. So the last and final step we have is history of catches. What is history catches? It is the kind of history given in the stems most of the time, so that we can easily just see how this murmur works with history, like if it's infective and congenital clues are given. Number one, IV drug use, endocarditis, tricuspid regurgitation. Most of the time if you see IV drug use, it is endocarditis pathology, and it's most commonly tricuspid regurgitations, it would be the answer. Fever, new murmur, septic emboli, increase in inspiration, these are the key information given in the stem of the questions. On you will see these kind of questions on QBank in step 1 and step 2. Fever, new murmur, septic emboli, increase with inspiration, and if it's IV drug use, then endocarditis, tricuspid regurgitation is the murmur you have. Secondly, bicuspid aortic valve, young males, early aortic stenosis. If you see a questions where there is early aortic stenosis in mostly 40s and 50s, it is due to bicuspid aortic valve. Young male, it is early calcifications, radiates to carotid. Same aortic stenosis, but aortic stenosis most commonly occurs after 70 due to calcification of aortic valve. But when if it occurs early, like in 40s and 50s, it is due to bicuspid aortic valve. Congenital bicuspid aortic valve is the cause of aortic stenosis in men or women 40 to 50 years of age. Next up is senile degenerative valve aortic stenosis, elderly, mostly 70 65 years of age of people, and it's normal age related aortic stenosis. 70 plus years, angina, syncope, calcified valve, it is senile degenerative valve. Next up, rheumatic, connective, and ischemic. Rheumatic heart disease, mitral stenosis, most common cause. Rheumatic heart disease, mitral stenosis, history of sore throat, opening snap, immigrant. Whenever there is immigrant in the stem, the most likely murmur or pathology it could be its mitral stenosis. If it's a connective tissue problem, next up we have Morphin and Ehlers-Danlos, mitral valve prolapse or aortic regurgitations. The history clues can be tall, thin, mid systolic click, pounding pulse, and it could be due to Marfan or Ehlers-Danlos syndromes. Next up we have post-MI acute mitral regurgitation. It can be post-MI, just think of it, MI causes the heart to dilate, and when it causes the heart to dilate, the blood would flow backwards, and the most common location for it's mitral regurgitation. New murmur plus pulmonary edema, it's acute mitral regurgitations. Now, physiologic and summary: pregnancy, anemia, thyrotoxicosis, they all cause flow physiologic murmur. Like there would be murmur which is benign murmur. There is no structural lesions, resolved postpartums, and soft in pregnancy, anemia, and thyrotoxicosis. So, quick summary uh, for this all is, if you see IV drug use, it's tricuspid regurgitations. Young plus bicuspid aortic valve, early aortic stenosis, it's early aortic stenosis. Old plus calcified, it's aortic stenosis due to degenerative calcification of the aortic valve. Rheumatic fever, mitral stenosis. Marfan's, mitral valve prolapse, and aortic regurgitation. Post-MI, mitral regurgitation. Pregnancy, flow murmur, it's physiologic. Anemia, physiologic. Thyrotoxicosis, it's physiologic. In the end, some question mentions the intensity of murmurs. It's 1 2 graded like 1 2 3 4 5 6. So remember, whenever you see 1 2, so 1 2 is never the problem. Like 1 and 2 intensity, if it's written that the intensity of murmur is second graded and it's a systolic murmur, so most likely chances are that that murmur is a benign murmur. Diastolic murmurs are always pathological. Systolic murmurs, grade 2, they are simply benign. They can be benign. Okay, thank you. And that complete 5-step murmurs algorithm, I put this together because murmur used to genuinely stress me out. There's so much to remember and it's all starts to blur together, but once I built this framework for myself, it just clicked. I hope it does the same for you. If this video helped, please hit like and share it with your study group.